Okay, I think we're going to listen to Franz, and then we will have a discussion at the end.
Thank you very much, Tommy. Yes, I think a very good talk. Thank you very much. What you pronounce is that the Medicare aspect is there. But the problem is that this the population doesn't realize. The medicine doesn't realize. They think, okay, this is the scientific truth. So I want to point out the view a little bit more on the contra side here of this Roman Janus hat, and want to go a little bit more in detail in the arguments of the Uspstf. I think the statement was discourage the use of this service. This was the statement. And as you mentioned before, we have to look to the situation in the United States. We have a lifetime risk of 17% to get a diagnosis of prostate cancer. This is 4 times as high as the mortality rate. You cannot compare this to Europe. It's like mass screening. Or, as you told before, at the rate of 25% receive a yearly PSA test. And at the age between 70 and 80 years, 45 get a PSA test. This is mass screening, really, absolutely. And on the other side, 80% of the surgeons in the United States make less than 10 radicals per year. And low-risk patients receive curative therapy in 90%. This is also far from the reality in Europe. So I think the USPSTF had to react to this overflow. I understand it. And perhaps it was based on this Time magazine in 1996, where Mr. Schwarzkopf don't want to be a B-type and to have a cancer growing inside of himself and do nothing. I think this is a mentality we have to realize as the basis of the decisions. But now let me come to the arguments, and I think a lot of them I cannot follow. Or the statement was that the 2 largest trials highlight the uncertainty, the RSBC, insignificant reduction, also the PLCO, insignificant increase. And the problem is they don't realize that we have to wait longer than 10 years for prostate cancer. We only treat patients who live longer than 10 years, and nobody told them that they cannot use facts after 9 years or so. This is a special thing to realize. Then they use this meta-analysis from a journal to support their statement, and they also looked to the PSA level and stated that there is no level you can be really free from prostate cancer and so on. And I want to go to this. And I'm happy that Dr. Aarau today make another message. This initial paper showed us that this trial in this configuration was not able to answer the question benefit of screening or not. This number of participants would have been sufficient to have to show a 27 reduction in prostate cancer mortality if the compliance would be 90% in the screening group, and in the control group 20% maximal would have a PSA test. The reality was others. Everybody knows this. We heard this before. So a contamination of 56% was not able to document this benefit. I think now we hear it, but the communication was not done in 2009. And this I regret really, because it made a lot of difficulties in Europe. So I already mentioned the other problems the PLCO trial had. You eventually this 44 pre-screening, and if you have a baseline screening, you reduce mortality. You can see this that in the ESBC arm and the control arm, we have twice as high prostate cancer deaths compared to the PLCO trial. The delayed entrance of the participants between 55 and 60 years needs to have a follow-up of 13 years, and we don't see a missing shift in the staging in the PLCO trial. So this trial was not able to give an answer, and now I think it's perfect to have this statement today. It shows no benefit, I repeat it, organized versus opportunistic screening. And this is point, I think it's also important to see now in the PLCO trial, we have our overall mortality of 5,783 compared to 5,982 in the control arm. And this I mean is a sign what overall mortality is very careful to handle with. In this sign here, you have a higher mortality rate of prostate cancer in the control arm, in the screening arm, but in the screening arm also you have a less high overall mortality. So you cannot use overall mortality for judging a treatment or screening program. You can use this in a treatment regimen in the SPCG4 trial, where you have no treatment or active treatment. Then you cannot take overall mortality, but not in such a screening population. Going to the meta-analysis from Illich, they used PLCO, ERSPC, and there's no copying study. And everybody knows this is mostly DRE-driven. 56% only have local disease. And the authors themselves stated that the power was not sufficient to show any benefit or harm in this study. The Stockholm study is the same. Only 11 from 65 cancers were treated. And the Quebec study, everybody knows there's a selection bias and no blinded data committees. This study was mentioned a lot of time today. I want to focus on a special thing. You see in the screening arm there were 44 deaths and 17 of them were non-attendees and 27 attendees. And looking here from the 27 attendees, 13 were greater than 60 years at beginning of the trial. We have this interval population between 50 and 65 years, and if you start screening with 62, for example, the tumor has more time to develop, so this kind of patient has a higher risk of death from prostate cancer. And I think this is really very well documented, that benefits in earlier times for screening 50 to 60 years could greater than start at 60 years or farther on. And once again, this benefit was documented by a 40% active surveillance procedure at the beginning. At the end, 1/3 of patients stayed with active surveillance. And now coming to compare in medicine, what is really the harms and the benefits and the number necessary to treat in other diseases. We heard about this. We have here 8 to treat in the Hugelson study. It's a question of time. When we look to the SPCG4 study, we have 7 to treat under the age of 65. And in this study, a treatment study, the overall mortality was reduced in the treatment arm. You have to realize this. When everybody spoke about overall mortality, which is not existent in this study, it's a treatment study, it exists. Looking to mammography, I think we have less results. There are 10 to 16 women to treat to save one life. The numbers of screening are more and higher than in prostate cancer, and mammography is more expensive than a PSA test. Flexible colonoscopy, the same, 489. And please remember, if you want to spare one death with an implantable cardioverter, you have to treat 16 patients. If you want to prevent one death with the ACE inhibitor, you have to treat 110. And if you want to do this by a beta blocker, you have to treat 40. These are the data, and beta blocker has also side effects. It's not the same harms like we have in surgery, this is clear, but we have to look to with a general view to the medicine before we decide what to do there and there and there. What I missed also in the USPSTF was the morbidity in dying with prostate cancer. You know, this 5% here, they die with prostate cancer, but they suffer also from this cancer. We know this from old publications, Aus, Fossa, and so on, and valve, TURP, incontinence, potency problems, palliative radiotherapy, they are existent in these patients here. And androgen deprivation, I totally agree to the Uspstf, too early is bad. We have really to spare this, but we have to do it sometimes. And when we have to do it, the risk of coronary heart disease increases, the rate of infarction increases, and so on. Let me come to the PSA, where they're told that there's no PSA level where a man can be guaranteed to be free from a prostate cancer. This is based on the PCPT trial from Thompson, 2,859 people, and they made the prostate biopsy, and in the range between 0 and 3, they found 2% of prostate cancer, of high aggressive prostate cancer. But this is a static snapshot, not a dynamic. Now we have the data from the RSPC, from the Swiss group RSPC, and we have the follow-up of 7 years. And look what is happening to this man who had a PSA between 0, 0.9, 1, 1.9, or 2 and 2.9. There are only 0.39% developing aggressive cancer, not 2%. This, I think, clinically we have to look for. So in my opinion, PSA ignores most minimal cancers. PSA is a strong risk calculator, I will show you. It's clear elevated PSA has a low specificity, but we have now to use it intelligent. Why? These are the Swiss data about the follow-up when a man had a PSA 0 until 0.9, 2,100 men, and after 4 years only 0.02% develop Gleason 7A or more. This is very minimal. And if you look after 8 years, this percentage is also in the per mil level. So we can really spare controls for a lot of years if a man is in this range. And we can spare cost, as you mentioned. And looking to this range, 1 to 1.99, we have also the numbers in Switzerland. 1,280 men, and after 4 years, only 0.3 develop prostate cancer 7A or greater. After 8 years, it's another thing, it's coming to 2%. I think this is a discussion, but we can delay the controls. And looking how is the amount of this man, then we see that in Switzerland, in the age 55 to 70 years, 75% of men are in this PSA range. So really we can make a program with risk reduction and to spare costs. And coming now to prostate cancer in older ages, I agree to this. Only 15% die from prostate cancer under the age of 64. The main portion is between 65 and 84 years. But we have to look that in the future, the life expectancy of a man in the age of 65 is 19 years. And every year it's growing up for 3 months. So prostate cancer will become a more healthcare problem than today. And now let me go to you published the harms and in 2002. This was 2002. I think the harms is a question of caseload and of identity of the surgeon. Look, these are high caseload centers at the continence rate. And harms is also a question of age. We don't want to operate the man above 70 years. We want to operate this age, this class here, this age of class. And then we have less problems with potency, less problems also with continence. So let me summarize. The data, our problem in the United States is mass screening, and the data are misinterpreted and too early interpreted. More detailed individual decision-making is necessary before testing candidates at this age. Overdiagnosis is a problem. Intelligent use of PSA or risk calculators is necessary. We have to support active surveillance and to look for comorbidities, we will hear afterwards. And to reduce the side effects have to really be reduced by case load. Now we can start fine-tuning. We have a lot of data available. We can start with this. And as the farmers here in the valley say, not every early detected tumor has to be treated, but the tumor which needs to be treated has to be early detected. Thank you very much.
Well, thank you, Franz. That was very interesting. I think the both talks, they reflect very much the problem we're in. It reminds me of two airplanes in different airways. Both of them are right, but the question is who is listening to whom? So,
Jonas, do you want to make a comment?
I have a comment to Peter about it. I'm a bit curious about this, why they make a grade D recommendation instead of a grade C recommendation. And I'm also curious about what happened in the United States. For 20 years, they have recommended PSA screening. And now when we have results, then you suddenly turn the other way around. So I can say Europe and the United States does not seem to be in exactly the same rhythm.
Let's start with the second statement. The U.S. Preventive Services Task Force has never recommended PSA testing, which is different from the lobbyists creating the law that has Medicare pay for PSA testing. Two different concepts. Lobbyists lobbied for PSA testing, legislatures approved it, so therefore Medicare pays for it. U.S. Preventive Task Force has never recommended PSA testing. Incidentally, they don't recommend mammography either. So they're not picking on the urologist for the exact same logic and the exact same arguments that they didn't recommend PSA testing. The grade D is basically a Cochrane-type analysis. It's their interpretation of the quality of the evidence, and they quite frankly looked at the ERSPC trial as not one trial, but 7 different trials. Because in fact, from a purist point of view, it really was 7 different trials because of all the reasons you explained. So when you looked at 6 out of those 7 trials, they were not statistically different. Only one was, the Swedish trial. So when you look at it in that context, they had 10 trials, PLCO, 6 ERSPC trials, the Quebec trial, which I agree was crap, and some of the other ones which are crap. But the point is they listed 8 of those, so the only one that was positive was the Swedish trial, and then they look at the data of the Swedish trial and say, these folks are different than everyone else. So when you put it in that context, they said the evidence doesn't support it, and that's why it got a grade D. Does that help?
I agree with that, but then you have still to look on the mortality development in the United States during the last 15 years, and I think that is also telling us something about the effect of screening, not only these screening trials which are still premature.
I have
and they did not discuss that very much about the mortality reduction.
That is not their mandate. Their mandate was to look at the specific question of screening. I think if you looked at that panel, they would all agree that prostate cancer mortality in the U.S. has fallen. There's no discussion, it has. The question is why? And they would argue it might be due to screening, but the evidence right now is pretty weak to support that. And if you, in fact, think about it, if screening has no effect for the first 10 years, and screening was only introduced in the U.S. in 1988 to 1990, yet the prostate cancer mortality rate began falling right about 1990. It's hard to argue the screening treatment effect is the primary explanation. I'm recognizing the modeling, and I know Ezione's works and the work that's spun here that suggests a portion of it is. But again, that was not the mandate of the U.S. Preventive Services Task Force. Their mandate was to specifically ask, was it screening that lowers it? And from the trials and evidence that are present, they would argue the evidence doesn't support it. And again, this is a political mandate. The analysis is scripted. It is scripted. They must do the meta-analysis. They must analyze all this. They can't introduce the nuance of we saying it's a crappy trial. They can only analyze it from the way it's technically has to be done.
Franz?
Yes. I think they have to know the natural history of this disease.
We all do.
So this is a problem. So if you judge something, you have really to know this kind of cancer, and make a political decision. I think it would be worthwhile to have a more insight to this. And looking to the mortality reduction in the United States, you have a good analysis from Mrs. Ezzoni, showing that 45 to 70% of the reduction in prostate cancer mortality is due to PSA screening. There are two different models. So this is a fact. And we in Europe don't understand that a ministry make decisions and proposals without really feeling the background of the disease.
Again, I just want to point out the role of the U.S. Preventive Service. It's a group of people to make recommendations or to evaluate for Congress to evaluate whether they should implement that or not. They carry no teeth of law.
Right. And may I add, I mean, the Swiss Medical Board did exactly the same thing, and they were mandated by the health governance and the Swiss medical. Well, I have a question, Franz. You said we need a differentiated schedule of screening. We needed to fine tune. Now that's maybe right and you also said that, but politicians who will at the end decide, they want simple questions, they want simple yes or no. How do we communicate with them? Because I think that's one of the problems, that we are not able to get to them. The numbers are so complicated, and you have to work on that. How do you think we should, what should we tell them?
I think it's about the financial way we have to do it. Or we have to tell them, okay, we can make reduction in mortality, and we can reduce costs in everyday praxis if we prolong, for example, the PSA intervals 8 years or 7 years or 6 years. And we have risk calculators which can spare 30% of the biopsy. Or perhaps we hear this afternoon that screening MRI is better than others. I don't know, but we have to do it on the financial way. Although I understand that they looking to United States. This is the only way they could imagine to follow us. Yes, Larry?
Peter, the thing that bothers me about the task force recommendation D, and it was a great talk and I understand the issues, but here you have a situation of a mortality reduction. And the U.S. Preventive Task Force said, we don't think that mortality reduction is worth the quality of life effects. Yep. But that to me is a very condescending perspective, because there may be a guy who is extremely well informed and understands the quality of life effects and decides he wants that survival benefit, even though the cost may look excessive to most people, but not to him. So to me, based on everything you've said and we've heard today, this screams it should be a level C recommendation, because there is indeed a mortality benefit. If the task force is denying that there's a mortality benefit, then they really have their head in the sands. And that leads me to the other point I want to make, which is, just as urologists are accused of having a vested interest and being emotionally tied to screening, etc., I think there's also a constituency of clinical epidemiology people and methodologists who have opposed PSA screening from day one. They don't like it. They think it's harmful, etc., etc. Not necessarily based on data, but based on ideology, you could say. And to me, the level D recommendation suggests that you've got ideologues on the task force who finally succeeded in getting a negative recommendation through, irrespective of the fact that any reasonable person would say, you know, maybe for somebody that mortality benefit is worthwhile.
Let's comment, your first comment. The U.S. Preventative Services Task Force does not prevent that person from getting all the screening he wants or all the treatment he wants. That's not their mission. That was never their mission. What they're saying is, for the 230 million people, or I guess 180 million men in the U.S., as a public policy to screen every one of those. They didn't say there was no benefit. They said there was little or no. The little was a nod towards the Göteborg study. The no was a nod towards the PLCO and all the other portions of the RSBC.
But that little benefit is still consistent with the level C. I'm talking about that. The key thing in the whole, no one out there is going to read the recommendation. All they're going to say is level D should not be done. That's the issue for me. It should be a C. Everything says it's a high cost, but maybe it's worth it for a few people, therefore we'll take a neutral position. And that I still haven't really heard you justify.
And again, I don't have the C and D criteria, because that's what we would need to do, and I don't have them. I probably can try to Google them later this evening. But it comes down to, again, this whole process is extremely scripted, because in fact it is a political process. It is lobbying and consensus driven at the highest level of the US government. There are huge dollars riding on this, and therefore what the methodology has to be impeccable if it is a government-run study, because otherwise it is trashed by everyone else. And so therefore, when they do this stuff, they have to follow an absolutely scripted position. The level D recommendations are very strict, and Jerry's Googling it right now. I can see him, and we can read those definitions, but it comes down to there are definitions for C and definitions for D, and I don't have them off the top of my head, but that's what landed it, because it in fact fit that definition. Alex?
Alex?
A question which is actually not a definition, but I mean, with the mortality which is at worst 3.5%, even if you had a 25% risk reduction, you would never achieve more than 1% absolute, which means that just because of the mortality is low, there's no way that you can achieve anything which is beyond 1%. Now, at the population level, the health, the payers, do we have any slightest idea what the US could be, the Canadian government, any government would be ready to pay for the entire population to save 1% or less than 1%? Because at the end of the day, it also boils down to what, and you pointed right, it doesn't prevent anyone to go and seek a PSA testing and get operated. That's not the issue. It's just really to have it. And it's more a communication problem then, and maybe it's up to us to try to communicate better. Maybe it's our fault, not necessarily the fault of the others. So do you have any slightest idea what the US and some of these guys would consider of the strict minimum to warrant that it would be reimbursed or paid? Or
That's, again, not quite the perspective they're coming from. I can tell you all preventive services are being met with a lot of skepticism by the U.S. Preventive Task Force in general, because of the huge costs associated with them and the question of how many lives you're saving. Vaccines, pretty modest investment, documented savings in lives, those get positive recommendations. We have evidence for mass vaccination. But again, you have to put on a public health hat. You can't come at this as an individual physician treating an individual patient, because the dissonance doesn't work. But you have to remember, these task force are recommending governments who are responsible for spending a huge budget on different priorities. And all of the preventive services not just prostate, breast, colon, etc., are being called into question. The women have a better lobby fighting in favor of mammography, but in end, this is turning out to be, if you look at the evidence is actually fairly modest.
This I want to support, that we, may I?
Just
only one. We have breast cancer programs, or political founded breast cancer programs. Yeah. So there are two different kinds of thinking and observing the problems. So we cannot make in one point heavy this direction and the other we say no. Sorry.
No, there is one question, and in the meantime,
yeah, if it's all an economical matter, why don't we try and calculate the burden, the economical burden of all those men who are not screened, who are not cured, and go for nephrostomies, TURPs, and all that mess? I think there is a study, it was in the Urologic Clinics of North America, that put out that 40 days per patient were added And I think Jonas was in this study maybe. And 40 days per patient, that's a huge burden economically if you don't screen the guy and you don't treat him and heal him. So have you considered that cost in the US Preventive Task Force recommendation?
Again, you're asking us, I'm not a member of the task force, number one. I'm just here to, I'm just trying to help put the perspective and help you try to see things through a different lens. And that's what we had an open discussion here earlier. Those costs, it comes down to absolute numbers. The absolute numbers are very small.
There's one question in the back for a long time.
I have just one question. If you look at the Gothenburg study, it was a population-based study and very homogeneous. What about the population in the States in the PLCO study? One may suspect that eventually it makes sense to screen a black American. Is there any data for that?
I'll let Jerry answer that one.
I was still thinking about it.
The question is there, did the PLCO come up with a subset such as African Americans where screening in fact might make sense?
Well, we have some information on the youngest men. We have a little bit of controversial information on the no comorbidity group of men, but these are all post hoc defined subgroups, and that would be hypothesis generating. So you would say, oh, okay, you think that's the case, there's a pretty significant difference for those men with absolutely no comorbidity who were young. All right, let's do another randomized trial that's powered to show that, and that'll take you another 15 to 20 years.
I have one comment. I agree with a lot of the statements in the report, actually. I think we have to make some changes, especially in the United States, how to screen for prostate cancer. I think everyone can agree about that. And I also think we have to admit that we need more studies, we need more results before we can say definitely what the advantage with PSA screening is. I think everyone agree with that. What I do not like with that report is how one has skewed the scientific data, because they have taken, for example, the Norrköping study, which is 870 men, and say this is a negative study showing no effect of PSA screening, and they have not used the data from the United States with 39% mortality reduction. That gives me and myself an impression that they wanted to show that there are a lot of studies showing no effect, and they go to very small studies, for example, these two Swedish studies, the Quebec studies, which are not they were designed for this issue, and that it troubles me, because that gives me an impression that was the result they wanted to present.
No, I disagree a little bit, and it comes down to the methodology. They're charged with looking at the literature and at randomized trials, not at models. Models didn't come into the, even though you and I understand models, that's not what their charge was. That's not what their mandate was in the meta-analysis. They had to go do the literature search for randomized trials, and the Norrköping one comes up.
But they stated that these trials would be able to give an answer to the question. This was the point.
Yeah.
And I think this is not so perfect in the thinking. Let me make one comment to your slide. Sorry when I say this. You mentioned that in the screening trial and in the control trial, we have the same amount in percentage of Gleason 7 to 10. You have to realize, you have to separate this, 7, 8, 9, and 10. And then you see that the high-grade cancer are less in the screening arm. You can also see this now in the New England Journal paper, that there is a total shift for the screening in less aggressive cancer. So I think you have to think about this slide there. The new paper is presenting the data for this.
Well, may I? Okay.
Okay, I'm Anders Björtelman, I'm Sweden. I would like to discuss a little bit with Jonas here and with everyone. In Sweden, Jonas has been extremely successful driving the Swedish brands of the screening trial. And the results show clearly survival benefit. In Sweden, we have exactly the same recommendation as the US task force. No screening. So Jonas, if you are even better, would you then like the Swedish government to recommend screening? I don't really think that is what we want to have in Sweden. I think this is a very interesting discussion. Sweden has been so successful, but we have exactly the same recommendation as the US task force. The US task force has made a lot of people so upset. Jonas, are you upset by the Swedish government?
But I do not really agree with you. I would say that I would never recommend Sweden to start screening, but I would say that the standpoint from the Swedish state for the moment is more a grade C recommendations. It's up to the individual man to take his own decision whether he should have a PSA test or not. And if he, after information, wants to take a PSA test, it's paid by the government money. So it's more like a grade C recommendation in Sweden today. So I'm amazed. Sweden have now a grade C, and United States a grade D recommendation. That's why I say we are not in the same rhythm for the moment. You agree that we have that?
Yeah, I believe so. And I think everyone agrees that we've all seen a lot of patients who should not have been detected as prostate cancers, old, very small cancers, etc. That's not what we would like to see. So I don't think we all would like to have a recommendation for screening. No. So I think we are just where we should be today. Exactly.
Well, I think that was a very interesting session. We probably could continue till Sunday on this topic. There are